Hello, everyone. This is Stephanie from the Center for Arab Genomic Studies, and I'd like to welcome you all to this sixth webinar, part of our CAGS webinar series. This series is organized by us at CAGS and our parent organization, the Sheikh Hamdan Award for Medical Sciences, and it's supported by the Dubai Health Authority, the Emirates Medical Association, as well as the Ministry of Health and Prevention. And the topic for today's webinar is genetic counseling. But before we move on to today's webinar, allow me to take a few minutes to tell you about our upcoming event, and that's the 9th Pan-Arab Human Genetics Conference. CAGS is organizing this conference, and it will be held on the 8th and 9th of December 2021. And the theme we've chosen for this year is Genomics in the Arab World, Opportunities and Challenges. And in order for us to allow delegates to participate, local, regional, and international delegates, we have made the registration for the conference completely free, and it will also be a virtual conference. If you'd like to register or if you'd like to submit an abstract to showcase your research, please visit the conference website, which is AAGC.com, and we'll actually put the link in the chat for your reference. And the conference will have a dedicated forum on genetic counseling, and this forum will be run by the Arab Association of Genetic Counsellors, and you'll actually be hearing from two members of the AAGC later on during the webinar. Back to tonight's webinar, I'd like to introduce you to our moderator, Alan Taylor. Alan is an American board-certified genetic counselor who received his master's in genetic counseling from the Northwestern University in Chicago, I believe. Then after he graduated, he held both clinical and lab positions at Boston Children's Hospital, as well as Claritas Genomics. And then he moved over to this side of the world. He moved to Dubai, and that was in 2018. He joined Jalila Children's Hospital, and he continues to hold both clinical and lab positions, where he counsels families who have a genetic diagnosis or who are planning to pursue genetic testing, and he also coordinates genetic testing across the hospital. Alan, thank you for moderating this session, and over to you.
So again, good evening, everybody. Thank you for joining us today. Let me just pull up my screen here. Thank you very much for the Center for Arab Genomic Studies for actually hosting today and allowing us to talk about genetic counseling, which is a subject very close to my heart. And again, thank you for Stephanie for arranging everything behind the scenes. So just before we get into the talk itself, just some housekeeping we want to take care of. We've got a question and answers box within Zoom. So as the talk is going on, please leave your questions in there, and then we'll select them and discuss them with the panelists at the end of the session. Any CME certificates will be downloaded as of tomorrow. There is a link here, so please use that link. That's how you get your CME certificates for those who are looking for them. And also, when the talk is over, please take the short survey at the end. It'll only take 1 or 2 minutes. So with that, and we'll just proceed. I'm just trying to move to the next slide here.
Alan, you might have to enable editing. Yeah.
Okay. Can we see the next slide?
Yes, yes.
So I've got the pleasure of introducing Miss Mona Saleh. She's our first speaker of the evening. She is an Arabic-Australian genetic counsellor with over 25 years experience with individuals and families in a variety of settings, including prenatal, adult onset conditions, fertility, and pediatric genetics. She had previously obtained a PhD from the University of New South Wales and applied her research to improving access to genetic service to minority groups. Mona has a passion for education, and in addition to her clinical work, Mona has worked in a number of senior educational roles, developing and implementing a number of educational strategies in numerous institutions. She has contributed to developing curriculum and research programs of a number of Master of Genetic Counselling programs in Australia. And her most recent role in the UAE University in Al Ain, she has been developing the master's program in genetic counselling, which is the first of its kind in the UAE. So I'm going to let Mona take it from here, and she's going to be discussing a new era of genetic counselling in the UAE.
Thanks so much, Alan. I'll just share my screen as well so we can get going. So hopefully my slides are up and running now. And I'd like to thank Stephanie and the team at CAGS, as Alan did, for doing all the work behind the scenes. You can see my slideshow now?
Yes, all good, Mona.
Fantastic. Thank you to the CAGS team who have organised this webinar and the other webinars which I've attended, and they're all fantastic. And I appreciate you including genetic counselling as a topic, again, which is close to my heart as well, obviously. So my presentation today will really be an overview of the genetic counselling landscape in the UAE and what I've learned working at the UAE University over the last 12 months about genetic counselling in the region. And I must say that at the onset, it's really an exciting time to be working in genetics in the region. And I'm really honoured that I've been able to spend some time there and contribute as well. So for those of us who don't really know what genetic counselling is, I thought I'd just give a little bit of a brief overview of what genetic counselling is and what genetic counsellors do, because it is a fairly misunderstood profession. Even working at the university, a lot of people are really fascinated to hear about the things that genetic counsellors can do and what impact they can have in the genetics area. So genetic counselling very basically is a communication process. So it's about communicating with individuals, couples and families about a genetic test result, a genetic condition or a health condition that has a genetic component in it. So while that sounds quite simple, and we know that there's lots of new genetic technology, and we understand a lot about genes and how they impact our health, as we know, people are complex and genetics is still complex, and there's a lot more that we don't understand. So it's a really difficult area for families and couples and individuals to navigate. So I think genetic counsellors have a huge role in helping people navigate that genetic landscape. So exactly what do genetic counsellors do? So I think genetic counsellors really have a two-pronged skill set. And the first one is about information and education. So it's about helping the family understand what is actually happening. If there's a diagnosis of a genetic condition, what does it mean for me? How is it inherited? What does it mean for other members of my family? Because as we know, genetics is not about individuals. It often implicates a risk or a risk factor for other family members, siblings, and sometimes people that you may not have a good relationship with in terms of communication. So genetic counsellors play a role in all of that information and understanding and education part. So they have that knowledge about the genetic conditions and how they work and how they actually impact on an individual and a family. But genetic counsellors also have this second flip side of their skills, and that's the counselling skills, where they look beyond the diagnosis. They look at how does this fit in with this individual and family? How is it assimilated into their life? And as I said, people are all different. And so genetic counsellors really have an important role in getting to know a person and getting to know and understanding how this will impact on them and helping guide them through that process of understanding genetics and perhaps making decisions with the information that they're given in a genetic counselling session. So I really like this diagram, which is from the American Society of Genetic Counsellors, which talks about some of the things genetic counsellors do. So they provide education, they assess risk, they provide support and advocate, they explain test results, and they also facilitate decision-making. But all these things, while they're clear, will impact on people differently. And that's because people come from different cultural backgrounds. Some people are very trusting of the health service and other people are not. It'll depend on people's coping mechanisms. their education levels. Some people are real information seekers and they want to know everything about a genetic condition. They want to understand, if I take this path, what does that mean for me? And if I take that path, what does that mean to me? Whereas other people feel really out of their depth and often like to hand over the decision making to the health professional. And that can be difficult too, because as a health professional in genetic counselling, you're not there to make a decision for a person. You're there to help them understand the options and work towards a decision that's best for them at that time. All of these things from a genetic that a genetic counsellor discusses with people can also be impacted by their family situation. And do people have that family support? Particularly in the UAE, where often people come to the UAE on their own or with a nuclear family, you know, often there's not that extended family support. And if there is a health condition or an issue diagnosed in a child or an individual, there can sometimes be that support missing. So genetic counsellors will explore that side of the genetic counselling process as well. So, as I mentioned earlier, genetic counsellors, often their role is a little bit misunderstood because there's often a team involved in a genetic clinic. There'll be genetic testing results, so sometimes the laboratory will have some input. The clinical geneticists who are medically trained and specialise in diagnosing genetic conditions and discussing genetic conditions, they're often involved in the genetic counselling session. Often, if you're in an obstetric hospital, obstetricians and gynecologists will provide some genetic counselling, but really the genetic counsellors as professionals provide that whole approach of discussing the science and the medical side and the implications of a genetic test or diagnosis, as well as that supportive and psychosocial whole picture aspect of the person. So coming a little bit closer to the Middle East and what's the situation with genetic counselling at the moment? I mean, we know that unfortunately the Middle East has a high proportion of genetic conditions, but again, unfortunately, it's an area where there aren't many genetic counsellors trained in the area. So training of genetic counsellors in the Middle Eastern region is really in its infancy. And so that's an area which I think is really important that we need to address, so that although we have some wonderful clinical geneticists and other specialists who provide genetic counselling, we really need to build up our cohort of professionally trained genetic counsellors who can work with the community in the Middle Eastern region. So this paper, which is probably the most recent paper published in 2019, looking at the worldwide aspect of genetic counselling and where there are training and how many genetic counsellors are working, there's so few in the Middle East that they were actually grouped with the European genetic counsellors. So if you look at the Middle Eastern region, there's probably well, this is my estimate, so don't quote me, and I truly hope I'm proven wrong. I feel that there's probably about 15 people working as genetic counsellors within the Middle East. Most in the UAE, there are some in Saudi, Lebanon, Jordan, and etc. And again, I hope I'm proven wrong. And during the Q&A later this evening, maybe you can put up your hand if you are a genetic counsellor working in the Middle East and we don't know about you. We'd love to connect with you, because I think the only way that we can grow is to build that momentum together, to educate health services, policymakers about the importance of genetic counselling as a profession and help build it up together. So stay tuned, there'll be a bit more about that later, but I think that this is a wonderful opportunity that we can address this shortfall of Middle Eastern trained genetic counsellors. So as Alan introduced me, I'm working at the UAE University in Abu Dhabi at the moment. Genetic counsellors are able to be licensed through the health departments both in Dubai and Abu Dhabi. And this is the qualifications and requirements that are needed where they can be assessed for that licensing. We have the Masters of Genetic Counselling that we're developing at the UAE University will will be one of those master's programs which will fulfill the requirement for this. Obviously, you need to do the other things, such as the 2 years experience and so on, to obtain your license. But we're very excited that our master's program, once it is up and running, will be part of this licensing program for the UAE. So just a little bit of an overview of the master's program. We're developing it along the guidelines of the Accreditation Board of Genetic Counselling. So this is a US-based accreditation board. And what they do is that they assess genetic counselling master programs. Currently, they only accredit programs in the US and Canada. But we are hoping that because we've built our master's program around their competencies and around their skill base for genetic counsellors, if and when they do start accrediting genetic counselling courses, we would also be able to apply for that and hopefully be successful. But we know that it is a good benchmark for us to develop a master's program, because the US and Canada are by far the area of the world where genetic counselling is the most progressed as a profession. So the Master of Genetic Counselling covers 3 components. As I said, genetic counsellors have to be quite well-rounded in their skills, so they need to learn the genetics and the genomics. They need to understand the genetic basis of disease, because you can't explain something, you can't simplify information unless you understand it well. And remember, people that are coming into the master's program would have already finished a bachelor's degree in a science or bioethics, nursing, or some other sort of health-related area. So hopefully they'd have some basic knowledge of science and health and biology. In addition to the genetics knowledge, there's a lot of skill work in the master's programs, which are 2 years. So there's a big component of placement in clinics and in community services or support groups. So looking at what is the real world for a genetic counsellor and what is the real world for people who are living with a genetic condition. We also encourage students to develop their communication and presentation skills so that they're able to be able to tailor information to people from different cultures, people from different education levels, give them that skill set where they're able to facilitate that education at whatever level is necessary. And an important part for genetic counsellors, especially in that we're working as genetic counsellors, not only in the clinical role, often in the laboratory role as well, having those ethics and research skills and being able to understand how to ethically implement research and work with researchers who are looking at researching families in genetics. So the program will hopefully be up and running in the next 12 months or so, but we're really keen to, again, encourage people to engage with genetic counsellors, to perhaps look at genetic counselling as a career if you're looking for a wonderful opportunity to help people. We know that there's going to be a lot of demand for genetic counselling in the UAE, and at the moment it's a blank slate. We don't really have much knowledge about who's doing what and where. And so we're hoping that, you know, in time there will be more coordination and more networking with the genetic counsellors. We know that there's a big demand. As I said earlier, genetics is a burden in the Middle East for families, unfortunately, with genetic diseases. There's also screening programs which are being increased, and there's been information released that the premarital screening program will eventually move to adding on some genes for recessive conditions. So there'll be more families identified as at potential risk for recessive conditions. And there's also the Population Genome Project, which will also show that we need more genetic counsellors in the role. But I don't want to leave this talk with feeling like I'm down and we haven't got enough genetic counsellors. So here's something really positive. We had a lovely lunch in Dubai a couple of weeks ago with a group of genetic counsellors working in the UAE, and even a couple of them couldn't make it. But as you can see, we are coordinating, we are networking, and I think if you listen to the next part of the presentation, you'll see that it, you know, as I said at the beginning, it really is an exciting time to be working in genetics. I'm proud to be part of this in a very small way, and I'm proud to have been able to contribute to the master's program, and look forward to your questions at the end of the session. And I thank you so much for, again, the opportunity and for listening.
So thank you, Mona, for that. Like I was saying, very important to understand the basics of genetic counselling within the region so we can identify the challenges moving forward. Now, moving on to our next speakers, we will have Tamam Khalaf from iGenomics and Rawan Awwad. Their talk will be on genetic counselling approaches to variants of uncertain significance in the Arab world. First, I'd like to introduce Tamam. She is a Palestinian genetic counsellor based here in the UAE. She obtained her master's in genetic and genomic counselling from Cardiff University, Wales. In her current role, she is working as a genetic counsellor in iGenomics here in Dubai, where she counsels both English and Arabic-speaking patients all over the Middle Eastern region. In this role, she provides empathetic, non-directive counselling while considering the patient's cultural and ethical backgrounds. She's also passionate about the issue of variants of uncertain significance in Middle Eastern populations, hence the reason of our talk this evening, as she has dedicated herself to raising awareness about the need for diversity and inclusion in the field of genetics. Rawan is a Palestinian, American board certified and multi-state licensed genetic counselor who is currently based in Michigan in the United States. She specializes in physician education on genomic profiling of circulating tumor DNA in the oncology space, as well as patient counseling on pre-implantation genetic testing in the reproductive space. She obtained her master's in genetic counseling from the University of Minnesota in 2006. She's got 15 years of clinical and biotech laboratory experiences in the fields of preconception, reproductive, oncology, and pediatric genetics. Having witnessed firsthand the inequity of healthcare in the Palestinian territories, she's become passionate about improving genetic services for Arab patients globally. And from this, she's co-founded the Arab Association of Genetic Counsellors in 2019. So from here, I will let Tamam take over.
Thank you so much, Alan, for that lovely introduction. And thank you, Mona, for the snapshot on genetic counseling in the Arab world, as well as just the update on what's going on right now. I think it's very important, like you mentioned. It was a lovely talk. So as Alan mentioned, I'm Tamam Khalaf. I am going to speak to you today, along with Rawan, about genetic counseling approaches to variants of uncertain significance in Arab patients. So I'm going to focus on a case that I had, and I really want to see how you would consider this. So I received a case that was a referral from a neurologist. The case history was a referral for post-test counseling after trio whole exome sequencing. And it was about a consanguineous couple, Muhammad and Maryam, that had a 14-year-old son, Omar, who had developmental delays and congenital anomalies. They also had a 20-year-old daughter, Reem, who was completely healthy. So the plan was to do West trio for the parents and then the affected child as well, and that I would counsel them following the results. So once the results came out, it was quite a difficult case. So what we saw was that Omar had a variant in gene A. Gene A was related with autosomal dominant inheritance, and it was a variant of uncertain significance. Omar had a heterozygous variant that was apparently de novo. He also had a homozygous variant in gene B, and I'm using gene A and gene B just for anonymity's sake. He also had a heterozygous variant in homozygous variant in gene B that was present in his parents, and it's associated with autosomal recessive inheritance, but it was also a variant of uncertain significance. The next part was that both the variants in gene A and gene B were only partially related to the phenotype. So take a moment here and consider, how would you approach this case? Who's the patient in this case? What would you say? What would you do? So genetic counselors as genetic counselors, we have to take into account the psychosocial situation of the patient and the needs of all the different family members. So what we do is, as a first step, is we prep for the session. We consider who is the patient in this case. Is it Omar? Is it Muhammad and Maryam? Or is it Reem, who's at an age of marriage, we can say? We also considered how was this case referred? What type of pre-test counseling was offered? Who's the referring physician? And what do we expect the patients to know? We consider what the main concern for each of the parties is. For Omar, primarily, it's treatment options and management. For Maryam and Muhammad, it's care for their kids. For Reem, it's potential family planning. And finally, we think about what should we be covered in the session, including explaining the science, discussing the psychosocial feelings, and exploring the results with the patients. So what actually happened in this case? So what happened was, Maryam and Muhammad attended the session alone. Omar was unwell and was unable to attend. And they told me that their primary concern was Omar and his diagnosis. So the first thing I did was I explained the results and I talked about the different types of inheritance. I talked about autosomal dominant inheritance and autosomal recessive inheritance, because it's important that the patients knew the difference between both, seeing as how the results we obtained have an autosomal dominant gene and an autosomal recessive gene. The next thing I did was explain variant classification. And this is usually a difficult topic to approach. So I'm sure all genetic counselors and all genetic healthcare professionals have their own tips and tricks about this. I usually use a book. And I explained that we have, our genes are recipes to build the human body. And sometimes these recipes have spelling mistake, and that spelling mistake could cause disease. So I discussed the variant in gene A, which is the heterozygous, apparently de novo variant, because it is only present in the affected child. And I discussed the need for confirmatory testing in Reem to confirm whether this variant could really be contributing to the phenotype or not. The second variant I discussed was the variant in gene B and the need for segregation analysis for this variant. So clearly, the uncertainty associated with this case is on multiple levels. It's from the genes themselves, the fact that they're partially related to the phenotype, the fact that the variants are variants of uncertain significance, which means we don't really know, are they contributing? Is this the cause of the situation? So there's a lot of uncertainty surrounding this case. And finally, we discussed the uncertainty, as I mentioned, and how this relates to Omar, Maryam and Muhammad, and even Reem. So their next concern was Reem, and that's a very important point, is that when I talked about additional testing, the family refused. The parents flat out said that they don't want to involve anyone else in this testing, and they don't want to do additional testing for anyone else. So this added an extra barrier of communication, because we'd have to respect the patient's wishes and not talk to anyone else about the family. So we wouldn't know, really, is there a way to confirm this diagnosis or not? The other thing the patients were concerned about were Reem. Should Reem be tested? So as we discussed, Reem should primarily be tested for the heterozygous variant in gene A, but she could also be a carrier of the variant in gene B. The next thing they mentioned was Reem was about to get into a consanguineous marriage with her paternal cousin. Now, this brought up the issues of the risk of Reem having a child with similar symptoms to Omar, which brought us back to the uncertainty of, if these changes are really causing the condition in Omar, then potentially, if her partner is carrying a variant in the same gene. But again, this was a very big conversation to have, especially since Reem wasn't present in the session. So we discussed the uncertainty associated with the VUSs and how this applies to Reem and their family. And then we discussed the need for confirmation of these results. Again, the parents refused additional testing. Finally, Reem and her partner should be counseled separately in order to understand their risk and for them to make an informed decision about testing. So what should we note here? We should remember that not only is it important to talk about the science, but the necessity of psychosocial support should not be undermined by the need to provide accurate and succinct scientific information about the genetic conditions and the risk they pose to the individual and the family. So not only do we need to discuss the psychosocial, discuss the science, but also make sure that the parents and the family members are able to understand the implications of these results. So what happens next? Usually in the session, we give the results, especially if it's a results session. We explain the science as needed. We discuss the results in the context of the family history, which is what we did, and we follow the patient's concerns and questions. We explore the psychosocial aspects of the case. How are the patients feeling? There are often feelings of guilt and anxiety associated with these results, so we explore those with the patient. We create a follow-up plan, whether it's a referral to different specialties, referral to additional counseling support, and we agree with the patient on how to proceed. And finally, we summarize the session and ensure that the patients understand the essential points, both scientifically and from the psychosocial aspect. So after the session, usually we summarize the case and send a refer letter to the referring physician. We send back a letter. This is mostly done in the UK or the US. Sometimes a letter is also sent to the patient. Again, this is not really a practice done in the Middle East, but maybe this is something that can be implemented. And we write out our counseling notes that summarize the session. Most importantly, after the session, genetic counselors often strongly utilize reflection. What could we have done better? Were the patient's goals achieved? What else could we have done to support the patient? And most importantly, was the patient's autonomy and confidentiality maintained? So for counseling interventions to be effective, all the various elements of genetic counseling practice must coincide. Mona mentioned some of these, but they include, but are not limited to, appropriate counseling skills, adapting to the challenge of variant interpretation, ensuring that the patient-centered approach is applied throughout the process. So the approach of genetic counselors here is contracting, understanding, supporting, and communicating with the patient. As you can see in every one of these circles, the patient's needs are what's important. So the patient leads the session. We follow empathy, congruence, and unconditional positive regard as the 3 core competencies of genetic counseling, and the most important approach to ensure that we're non-judgmental, and a non-judgmental approach to the patients. So who are genetic counselors? Genetic counselors are healthcare professionals that have specialist education and training in genetic and genomics and assessed competence in counseling skills. Genetic counselors support patients in making informed decisions about their genetic health. This definition, honestly, it's a mix of all the definitions out there because there's not one clear answer of what a genetic counselor is, but it does encompass all the skills that we previously discussed. So one thing I want to point out is that actually the role of the genetic counselor, as Mona brilliantly mentioned, has actually evolved significantly even within the past year. We work in education, we work in labs, we work in clinics, hospitals. We also have specialty areas. So not only are we genetic counselors in general, there are cancer genetic counselors, prenatal genetic counselors, and that's evolved into cardiology, neurogenetics, metabolic conditions, additionally pediatric genetic counselors. So the role of the genetic counselor truly has evolved. I'm not going to go into this slide too much, but I do want to point out that there's significant literature on genetic counseling, variants of uncertain significance, and the association of uncertainty and the counseling that the patient receives and how that improves patient care. These are just a few snapshots of articles that discuss this. Finally, the main takeaway points are that the genetic counselor's approach to VUSs vary between populations. And this is a conversation that we can spend days talking about of how to approach a VUS and what's the appropriate method to discuss VUSs and to deal with them. We balance the scientific information with the counseling approach. We allow the patient to set the tone of the meeting. We communicate and conceptualize the uncertainty associated with genetic tests. We explain complex scientific information in an easy to understand way so that the patients can have all the information they need. And finally, we take into account all the cultural and ethical considerations possible. So that's just a quick snapshot of a very interesting case, and there are many cases like it in the Middle East due to the high consanguinity and the presence of variants of uncertain significance in the Arab population. So now I'm going to hand it over to Rawan to discuss the second part of our talk, which is the genetic counselor scope beyond patient counseling. Thank you so much for taking the time to listen to us, and thank you so much to CAGS, Stephanie, and the team for coordinating everything today.
All right, can everyone see my screen now?
Yes.
Excellent. So thank you so much to CAGS for having me today, for having the AAGC, and thank you everyone for attending. Tamam provided you with a beautiful introduction to what genetic counselors do, so did Mona, and I'm happy to take on the second portion of the talk. It's still going to be under the umbrella of how genetic counselors approach variants of uncertain significance, but I'll hone in on skills beyond direct patient counseling, specifically how genetic counselors use their genetic expertise and analysis for case management. Now, I do realize that how genetic counselors are trained and certified might be different in different countries. Just please note that I'm basing this on how it's practiced in the US, given that that's where I live and practice. And the American Board of Genetic Counseling has adopted really 4 domains, 4 core competencies for genetic counselors to be successful in what they do. That's education, both for patients, professionals, the public, interpersonal, psychosocial, and counseling skills, commitment to lifelong professional development and practice, as well as genetic expertise and analysis. And under the last domain are some skills that I want to highlight today, things like critical assessment of current literature, assessment of genetic test results, review of medical records, databases, resources, and communication with different entities like labs and clinicians in order to get the best health outcome for that patient. So my case was a case of a carrier of an X-linked adrenoleukodystrophy that was referred for PGTM services. And before I present the case, I really want to just clarify that PGTM stands for pre-implantation genetic testing for monogenic disorders, which is exactly the same as PGD, pre-implantation genetic diagnosis. So if you are in a country that's used to using PGD as a term, just know I'm referring to the same exact technology. And for the students in the audience, PGTM is a technology that's available as an option with the process of IVF to prioritize embryos that have a reduced risk to develop a specific genetic condition. And so my case today is really going to touch upon a few things. I'm going to show you an example of how expedited carrier screening showed a test result that led to a PGTM referral. I'll show you an example of differences in variant interpretation between labs and the downstream effect of that. I'll show you how genetic counselors' role in communication can be vital between different entities for the best outcome of the patient, and how we serve as patient advocates in improving the health outcomes. So this is a snapshot of my own carrier screening results that I had a few years ago. You can see here my name. And I had this carrier screening done, again, several years ago because of my own interest. And as you can see, 176 conditions were assessed, and I was found to be a carrier for steroid-resistant nephrotic syndrome. Now, being a professional in this field, I realized immediately that this particular variant, C.686G to A, or otherwise known commonly as the R229Q variant, is incredibly common in the population and can be mild, especially in the homozygous state. And I had already been done with family planning at that point, so I did not pursue any additional testing afterwards. And then a few years after, I pursued another set of carrier screening tests that I did through a different lab. You can see here the date. This was pretty recent, earlier this year. And both are reputable labs. And you can see the results were completely negative. When you look at the list of conditions they look at, there's 289 genes. And I did actually go and check with the second lab to see if they included the NPHS2 on the report. It's included. And I specifically asked if the variant that was detected previously for me was found. And sure enough, they were able to see it, but they classify it as a VUS. And I think right now they classify it as a benign. So it does not really appear on my results at all. And so this discrepancy that you see here is something that we see common in practice. It's seen commonly between different labs because of the different scientists that use interpretations for these variants. And you know, it can be a little bit of a shock for either a patient or a clinician that's not well versed in genetics when they see two different labs coming up with different results, because the first impulse you get is, who made the mistake? Which lab was wrong? But in reality, both did very similar testing and literally got the same results, but the way it's displayed is very different. When you go to ClinVar and look at this particular variant, you can see that there are 15 submissions from different labs and entities. And these submissions classify this particular variant into very different classifications. Some classify it as pathogenic, likely pathogenic, VUS, benign, and even a risk factor for nephrotic disease. And you're welcome to go check it yourself. You can see all these different conflicting interpretations of pathogenicity for my variant. And so then comes the question of, well, what does a patient do? And how different is her or his course of treatment going to be if they're getting different results solely based on the lab that they choose to test? And you know, just in general, for those who are not familiar too much with carrier screening, especially how it's performed in the US, these screens typically contain anywhere between several dozens to several hundreds of genes, usually recessive and X-linked, and only likely pathogenic and pathogenic variants are reported. Anything that's a VUS, benign or likely benign, is not reported. So you get a negative result completely. Just keep this in mind as I continue on with my talk, because it's going to be relevant for my case. So then comes the question of, I mean, should we really be concerned about VUSs? I mean, how often are they reported anyway? And it turns out to be a lot. So I did my search on ClinVar Minor. The website is below, just last month, to see, you know, what submissions have been, the number of submissions so far. You can see up here that there are over 1 million variants that were submitted to ClinVar, and almost 500,000 of those are variants of uncertain significance. So we really, it's a field that's growing in genetics, especially with the advent of next generation sequencing, and one that will continue to cause dilemmas. And this is a study that I'd like to highlight just because of these beautiful visuals. And it was also conducted by scientists in both the US and the Middle East. And it's basically looking at the lack of representation of Middle Eastern populations in genomic databases. And you can see here the databases that were surveyed, and beautiful illustrations that show that really less than 1% of genomic sequence data is from Middle Eastern population. And why is that an issue? It's an issue because it causes an inherent bias in how variants are classified. There are several factors that scientists use to classify variants, things like how common it is in the population, if there's literature available to show if there are individuals carriers for these variants that are affected with disease and association of those, functional studies, and other factors. So if we are underrepresented in these databases, then there's going to be, the classification is going to be suboptimal for our patient population. And the possible limitations for the inclusion of Middle Eastern populations in genomic databases can include, or may include, the stigma that's present about genetic diseases in the Middle East. You see a lot of patients that are hesitant to bring up information about relatives that may have genetic disease for the fear of stigma, and they also don't bring them to the medical attention because of that same stigma. There's a lack of education in general about genetic and genomic variants. There's a shortage of genetic counselors that may be providing this education, and we're hoping with efforts like the one that Mona presented that there's going to be more graduates in the Middle East with these skills to help the patient population. And then last, shortage of recruitment of, excuse me, Arab patients into clinical studies because of all these reasons mentioned. And so now that we've established what the issue is, I wanted to introduce you to my case. And so I had a Middle Eastern couple, Syrian to be specific, that were presenting to an IVF clinic due to difficulty conceiving. And as part of their fertility workup, they had a carrier screening result that showed that the female is a carrier for a likely pathogenic variant in the ABCD1 gene. That's the gene, as you know, that's associated with this condition. Her partner was negative for all conditions tested. Now, the couple had a brief consultation with their reproductive endocrinologist, and they were offered the option of PGT-M. I saw the patient for an initial consultation. I was at that time working as a laboratory genetic counselor in the PGT-M world, and she seemed hesitant about PGT-M. I consistently told her that it's an option that she is welcome to decline. It was just offered by her clinician, but she seemed very attached to it. And the way she explained it is that this was presented to her as the only option that's available to have a healthy baby. And because I've worked in this space for a while, I've come to realize that reproductive endocrinologists are typically not well-versed in genetics, and they are not expected to be. And so when they see a genetic test report that says a patient has an increased risk for an affected child, or if they get a note from a clinician that says that PGTM is available as an option, they consider these sources as sources coming from experts in the field. And so the automatic action then is to refer to a PGTM laboratory, and they also feel like having that positive report is a liability on their hands. So without offering that option, without offering their patient that option, it seems like they are doing a disservice for the patient. And that's why she felt like she was cornered into that option. So I did my homework. I went on ClinVar and looked at that particular variant of my patient. It's worth noting that this variant that you see up here is not my patient's to conceal her identity, but I've done similar searches for other variants like this one that are likely pathogenic in the same gene. And this is an example of what I saw in ClinVar. You can see here conflicting interpretations of pathogenicity, and then some labs considering as likely pathogenic, others as uncertain significance. And again, that's very common, especially for variants that are likely path, because you can tell that there may be differences in opinion about what they should be classified as. So I took this information to our session. I explained to her about the conflicting interpretations, obviously after we laid out all the information. And as part of the PGTM process, which is a little bit outside of the scope of this talk today, but we do use relatives for probe development. So linkage is part of the process of testing embryos. And so I obviously discussed with her the option of testing her parents. She was very on board with that, but I let her know that because her parents are out of state, they may be using a different lab that may classify this variant differently. And sure enough, fast forward a few weeks from that point, her father was the one that was a carrier for the same variant as hers, and it was considered through lab 2 as a VUS. And I put here that biochemical was not done for either of my patients, just because we do know that there's elevated VL, very long chain fatty acids for individuals who are either affected, or a portion of the carriers, females can also have elevated levels, but neither of these individuals were assessed during the time that I was assessing this case. So then you can see here, this is a male who's a carrier. It's an X-linked condition. And that left me a little bit suspicious with the actual pathogenicity of this variant. It's possible that there are different males in the same family that may exhibit different symptoms of the same condition, such that one of them could not be affected and the other one could be. But still, I wanted to dig a little bit deeper. And the patient felt comfortable at that point to share with me that at the initial time that she had testing, she was suspicious of her results because she didn't have a family history of ADL. And so she took it upon herself to go to a different lab, lab 3, got carrier screening again through that lab. This was not available to me as information at the beginning, but she shared with me after and shared the report. And her results were negative, of course, because that lab considers her variant as a VUS. And so when she got those conflicting interpretations, she became suspicious, and that's why she was hesitant about the PGTM process. So I felt like it was my duty at that point to help her out. There's all this information that patients and even clinicians are not really trained to navigate. And so I then approached lab number 2 and lab number 3 and asked them for the full annotation summaries of that variant. Here's an example of these annotations. You can see that they list the clinical phenotype and the primary literature that they looked at. There's one complex male with this phenotype for this variant. They look at databases. Again, that's the issue where there's an underrepresentation of Middle Easterns. They look at computation analysis, etc. So I took all this detailed information and I presented it to lab number 1, the original testing lab, to see what they think about these other analyses. And in 2 days, I heard back from the original testing lab letting me know that they decided to reclassify my patient's variant into a VUS, and they have amended the report. By doing so, now she has a negative carrier screening report. And that made a complete difference for her and her physician, because now she can have other alternative options for conception through a fertility clinic other than IVF with PGTM, such as intrauterine insemination, which does not involve the creation of embryos. She was incredibly happy with that option, and her physician even reached out and thanked me, because to him, he wanted to help his patient, but didn't know with that positive result on his hand. And so this case is really to demonstrate that genetic counselors do make a difference in patient management. If we put our thinking hat on, we can really help our patients maneuver the system, and we can help facilitate their decision-making and the case management itself, typically based on what they want. It's not what we need or what we want to show, but it is really always patient-centered. Third is the lack of representation of variants from Middle Eastern and Arab patients is currently a huge limitation. And as the next generation sequencing technology continues to evolve, there really is an immense need for more robust variant databases to help our patient population out. And I listed here 2 of these databases that are currently available in the Middle East. I'm sure there are more. I just put 2 examples that I came across. One sponsored by CAGS, called the Catalog for Transmission Genetics in Arabs, and as well as the MENA. And if you are a clinician, a researcher, or even a genetic counselor that's able to add to these submissions, you're really helping out the whole patient population in the long run. So this leads me to something that I am very, very proud of, which is the Arab Association of Genetic Counselors, الجمعية العربية لمستشاري الوراثة. This is an association that was developed based on common interests of various Arab genetic counselors across the world that got together and realized that we have a common mission. We do recognize that the Arab patient population has specific needs culturally, politically, socially, and there's really a lack of services, especially in the genetics world, for that patient population. So the AAGC was created to promote networking, creates resources, and encourages collaboration and research among genetic professionals in order to extend quality genetic services to the Arab patient population globally. So please note that if you are a clinician or a geneticist that's working with the Arab patient population, you do not need to be speaking Arabic to be part of this effort. We would love collaboration with any and all professionals in the genetics world that can help this patient population. We are mostly now a group of genetic counselors, and the membership is growing as we speak. We are proud to say that just today, the AAGC website is going to launch. I kept refreshing my website as I was waiting for my talk. I think it's going to go live pretty soon, if not live right now. The address is arabgen.org. It's going to help you find a genetic counselor locally or one that would provide services remotely. We're going to have blogs, patient tools and resources, and this website is going to be evolving. The first launch that you're going to see is very basic, but if you check in a few months and in a few years, it's going to continue to hopefully grow, inshallah, with everyone's collaboration. If you have questions for us at the AAGC, you can email us at support@arabgen.org. Thank you so much for listening, and we'll open up for questions.
So thank you for that, Rawan and Tamam. So let me just pop up one last screen, and I think we'll be ready for some questions. So just before we get to the questions, just a couple more pieces of information to everybody listening, that please, at the end of this talk, please fill in a short survey. It will only take 2 minutes of your time. As I mentioned earlier, the CME certificates will be ready tomorrow, and please tune in for our next webinar, which is on the 27th of October, which will be discussing metabolic disorders. So just getting to a couple of the questions that are coming in, I think you addressed a little bit, Rowan, at the end, is that the question is, how as genetic counselors or as physicians or healthcare providers, can we work on inclusion of this genomic data and help understand VUSs?
I can tackle this question. The first thing that I would recommend is that if you are in a position to be working with researchers or clinicians that are performing things like carrier screening, whole exome sequencing, or other sequencing technology that would help add to these databases, it would be of tremendous help to try and see if submissions of those variants can be done to those databases that we talked about. You know, the AAGC is established to see if we can collaborate with each other. I know that there potentially are scientists and clinicians out there that may be keeping track of these variants on their own because of either not knowing about these public databases or because they are, you know, they have their own baby, let's say, of research going on. So if we can open up access and share this information in the long run, we can learn from databases like LINVAR. It's going to ultimately really help our patient population.
Does anybody else have anything to add? No. As we were discussing earlier, the biggest issue is of just having numbers of genetic counsellors in this region. One thing we're very lacking in genetic counselling is a diversification of genetic counselling students. So there is a lot of questions about the actual program. So Mona, if anybody's interested in this program, can they go to the website for more information in terms of, you're just on silent, Mona. I think the questions are quite specific. Can they, how the application is, will they be applying this year?
Sure.
Will the information be on the website?
Yes, so the UAE University College of Medicine and Health Sciences has information. It says that the program is in progress, and it is, so we have to wait for the final accreditation from the National Accreditation Council in the UAE. The program and curriculum are ready to go, but we're just waiting on that final accreditation. So at the moment, we're not enrolling students, and obviously there will be a very small number of students enrolled initially because of that large clinical placement component. So because of the limited number of clinics in the UAE, obviously we have to take a limited number of students so that we don't add extra burden onto those already very busy clinics and clinicians. So looking at hopefully 2022 will be our first enrolments if all goes well with the accreditation, which is happening in this latter part of 2021.
Okay. Sorry, just one question came in. Let me see if I can see it. So I've got a question just about, and I think it goes more to a cultural issue more than anything. That's what I'm trying to dig into. Tamam, you said there's one family that didn't want to do additional testing after you seems like had a quite prolonged discussion with them. What was the reason for this, that they didn't want to continue? And does this speak to a larger issue with families who don't want to do testing for cultural reasons or religious reasons?
I don't think it was a religious reason per se. I think they just didn't want to, like the condition their son was going through was hard enough and they didn't really want to raise concerns. They weren't really sure how to bring it up to other family members, even though I told them we can support them with that. And I think this is something I've seen not just in my practice here in the Middle East, more so in just in general, patients have those specific preferences on how to contact family members. But I do have to say culturally, I've noticed, and I don't know if this is just from my patient population, that generally here the patients are more willing to share information. There's a lot more sense of community. So there is that idea of, no, let's help the family, but it is a very personal choice. So that's kind of the thing we need to take into account at the end of the day.
Okay. And here's another question from the audience is that, thank you very much for the talk, very specific issues to the Middle East, but they would like to know what's the advantage in comparing the Middle Eastern area to the rest of the world.
Sorry, can you repeat that last bit?
They're saying, what are the advantages of comparing the issues that we have within this region to the rest of the world?
So I'll just start on that, and I think Rawan and Mona can add on if they have anything specific to say. And I'm sure, Ellen, you have experience yourself, seeing as how you're a counselor here as well. The difference is that our population in the Middle East isn't studied as much as the external Western, let's say, population. there's a lot of variance here. And I've given a talk previously where the top variants that we see in Middle Eastern communities and in Middle Eastern couples are significantly different than the most common variants we'd see in a European couple or an American couple. So this is something that we need to take into account. Additionally, there is the cultural understanding where every country, even within the same country, every individual has a different cultural intake, and Arab and genetic counselors in the Middle East need to really understand those cultural differences. Counseling a patient from the UAE may significantly differ from counseling a patient in Jordan, for example, simply just based on the approach, what's acceptable, what's not. And this is something that really the intricacies of our profession need to take into account here in the Middle East.
And I'll add to what Tamam said to say that, as you know, there's a high level of consanguinity in our patient population, which makes the structure of the genome that we're looking at pretty unique. Because I come from the Palestinian territories and I worked there for a while, I can tell you that there are political restrictions as well in some of these Arab countries that directly affect how genetics is actually working, believe it or not. There are specific subpopulations in very small villages in the area that I grew up in where there are variants in the genes associated with deafness and hearing loss that has not been seen anywhere else in the world. So it's very unique, that it's a patient population that can be helped and investigated further.
And I guess just to add to this, the reason why we would maybe compare one region to another is that if we look to one region, look at the benefit, the outputs, look at the benefits of the amount of genetic counselors to the population, access to healthcare, looking at the challenges by compared, are we above or below somewhere else? Because everybody wants it to be at a certain standard. So I think that's what I would think about with why I compare one region with another and make sure that we're getting what we need for our patients within a specific region. As we've mentioned before, that even in this region, we're very under represented in terms of profession. And in America, where there's the most amount of genetic counselors, they had a study recently, and even in their best case scenario, in 5 years' time, they would consider themselves underrepresented for genetic counselors. So if you take it in a region like this, where very few genetic counselors, it will take many years before we get to a point that we would be considered sufficient volume to deal with the number of genetic cases. And as everybody has been discussing, because of the high levels of consanguinity, there's more genetic burden in this region more than other regions of the world.
Also, just to quickly add to that, every country in the Middle East has slightly different guidelines and rules that need to be adhered to and followed. So that adds that extra level of need to have sufficient genetic counseling support in the Middle East.
So just looking at time here, Stephanie, how much time do we have until we can stop taking questions?
Let's take a couple more, Alan. I know there's a lot, but
okay. There is, yes.
A couple more.
So I guess I just had a question for Tamam. Since you're here within Dubai, do you find it more of a challenge here than in other countries, just with the multicultural diversity that we see within this city?
Not quite, to be honest. I think it's refreshing to have that take, and I think it really helps develop myself as a professional in terms of genetic counseling, because you do realize the nuances as you see more and more patients. We tend to let go of the preconceived notions of how you should say something. I think we're really lucky here in Dubai that we have a multicultural patient population, from European, American to obviously Gulf countries, Middle Eastern, Levant, from the Levant, from North Africa. So it really is a very wonderful place to work in terms of understanding how to approach different patient populations.
One question, I guess, this will be quite applicable to the AAGC as it gets more developed, because there's not a huge amount of Arabic-speaking genetic counselors even within this region. Mm-hmm. How do you find counselling in person compared to video conferencing?
There's actually several studies that show that it's pretty comparable. There are studies that basically looked at patient satisfaction, the level of information they were able to learn and regurgitate back to a counselor through different modalities, whether it's Zoom meetings, in person versus phone, and it's pretty comparable. And the reason for that is because genetic counselors are trained to listen to cues that are not only physical. You are able to tune in to the conversation, to the tone of the voice, to the kind of questions that are being asked, to the background noise, how distracted the patient is, how involved the patient is. So these are all skills that you perhaps don't learn in graduate school per se, but you evolve over time. So again, in my personal view, it's been comparable, but I would love the other panelists to add if you've had different experiences.
So I've had counseling both in person and on the phone in Arabic, and Mona was so kind to supervise a few of my counseling sessions for my accreditation to the Canadian board. And I think, Mona, if you want to comment on that after, I think the counseling sessions, even on the phone, were really effective. I think, like Rawan said, we pick up on the nonverbal cues just as much as the verbal cues. We really use our counseling skills to the best of our abilities when it is on the phone, and we still try to reach the patient's goal. And as long as, I mentioned this in my talk, as long as we have that empathy, congruence, and unconditional positive regard for the patient, I think regardless phone or in person, we can achieve the goal of the the counseling session.
Yeah, I would just add that I agree with what Rawan said, that the studies do show that there is equitable efficacy and satisfaction for patients who are either having telehealth counselling or more recently actual video conferencing counselling, which is really fantastic. And genetic counsellors often, even before we had to go to counselling online, often had phone calls with families before they came to clinic, after they came to clinic for follow-up. So we really do, as the others have said, have those skills of connecting and understanding the non-verbal cues and the non-visual cues. So personally, and even as a consumer, I think you feel more comfortable in your own home to be able to express your feelings sometimes, rather than in a strange clinical space. If you're a professional who can establish that rapport with the patient, I think that they're in a good position in their own homes to actually express their feelings in a very real way.
And one last thing I would add to Mona, I 100% agree with Mona, how patients did actually say that it's much more convenient for them, especially during COVID, to be on the phone with a clinician while they have, let's say children running around, than actually making a physical visit to a clinic. But then I wanted to also say, we've been highlighting the shortage of genetic counselors worldwide. And so to meet the scale and the demand, we really have to think about alternative modes of genetic counseling other than in person. And the only way to meet that demand is to think outside the box and use things like phone, video, and even chat. The artificial intelligence now is on the forefront of trying to solve some of these issues as well.
Okay. We'll take one or two more questions. A lot of these questions are very specific, but they're very good. But I think just in the concept of today's talk, we'll keep it to the more societal level. That one person does bring up that trying to enroll patients who are willing to take part in genetic studies is always an issue. So can you suggest any possible ways to enroll patients to increase the numbers that we see in these public databases and therefore reduce the number of variants we're seeing?
I think the best tip I can give anyone is hire a genetic counsellor to the research project, because, as we've mentioned, the communication skills, the ability to connect with people, to develop that rapport with patients. I think it's a very trusting relationship. Genetic research in many communities can sometimes be seen as something dangerous or something risky, but hopefully that will change. And I think with the Emirati Genome Project, it will be a really positive outcome. Hopefully there'll be more information coming from that. I'm not personally involved in that, but I hope that one of the outcomes will be that there'll be a lot more data about the Emirati genome. And I know that that's only, one proportion of the cultural groups in the Middle East, but it is a start. But my tip for research would be get genetic counsellors involved, because often they bridge that gap between the medical science and the sort of the more scary side of attending a genetic clinic, and make it more of a personal experience. And they can help explain, you know, the benefits of the research, not only to that person, but to the wider community. So that's my tip.
I 1000% agree with Mona, especially because the counseling process itself is really an informed consent process. Think about a document that you're giving a patient and it's a consent for enrollment into a study. How scary is it? They don't know where their DNA is going, what's going to be done to it, for how long it's going to stay. So if you are that bridge that can explain all that information in a way that would create trust, then you might find a higher number of enrollment, especially if they feel like there's going to be also a return for them in terms of benefit.
So just with that, with this keeping in mind, it's everybody's evenings, I think we'll wrap it up there. Tamam, you said you're willing to share your email, because a lot of questions are quite specific and they're very good questions, but we don't have time here to answer them all, unfortunately. Hopefully we'll meet some of the attendees in person in our next conference and we can discuss in length. But
I think Stephanie shared the email already. If there are any specific questions to me, or if anyone needs any information about counseling services here in the UAE, I'm very happy to, you're more than welcome to reach me on the email, tamam.khalaf@igenomics.com, and I'm happy, or on LinkedIn, just message me on Tamam Khalaf and we can have a chat.
Yes, I'm available. I think I'm available on LinkedIn as well if anybody wants to follow up for further questions.
Same with me.
Okay, so that's a wrap, I guess. Thank you all very, very much. The talks were great and the discussion was even better. Alan, thank you for moderating, and everyone, really great talks, so thank you. To everyone who's attended and asked questions, we're sorry we didn't get the time to get to all the questions, but it's a bit late. So again, please reach out to everyone on LinkedIn or by email for any further questions. And as Alan mentioned, please don't forget to fill the poll that just popped up on your screens. And we have one more webinar in our CAGS webinar series, and that's next month, October 27th. So if you're interested, please register for that as well. Thank you, and have a good evening.
Thanks, Stephanie.
Thank you.
Thanks, everybody.
Thank you.